It is an incredible pleasure and delight to have Dr. Tammy Clifford with us here today. So if you will allow me, Tammy, I'm going to read your bio. So Dr. Tammy Clifford is Vice President of Research Learning Health Systems at the Canadian Institutes of Health Research, CIHR, where she provides leadership for the design, development, and administration of CIHR's funding programs and science policies related to learning health systems. In October 2018, she joined CIHR as a Vice President of Research Programs. Prior to joining CIHR, Dr. Clifford was its Chief Scientist and Vice President, Evidence Standards at the Canadian Agency for Drugs and Technologies in Health. Dr. Clifford received her PhD in epidemiology and biostatistics from the University of Western Ontario, as well as her BSc and MSc from McGill University. And it's just such a pleasure to have you here with us today. I will notice that the number of participants have gone up, Tammy, since your presentation is starting. I know we're all excited and looking forward to this, and just incredibly grateful that you took the time from your busy schedule to come and chat with us about patient engagement and the landscape of patient-oriented research in Canada and beyond. So we're incredibly excited. And I believe Sabrina will be pulling up your slides for you and advancing them for you. So huge thank you. And also to let you know that I will moderate the chat for you. So when we have time at the end for a few questions, I'll moderate those for you. So thank you so much.
Terrific. Thanks so much, Andrea, and thanks so much for running my slides. I'm operating from a laptop today, and I was getting a notice that my computer, we need to restart. So if it does turn out that I somehow get knocked out, I did restart, but I will rejoin you by phone, and at least the slides can continue even if I'm joining you some other way. So again, I just have to say thank you so much for the very, very warm welcome. I'm so excited to be here with you today. And as I was thinking through the presentation today, I realized that this is my first time at an Evidence Alliance meeting. And I have to say, I am aghast and ashamed because, of course, in my current role, in my previous role, in my previous role, I've obviously been very close to the evidence synthesis landscape. So perhaps, the saying of good things that come to those who wait is apropos here. So again, thank you to everyone who provided me with the opportunity to join you today. I will also note that I see many familiar faces or names of faces in the crowd. Janet, it's great to see you for the second time today. And Shannon, great to chat with you 2 days in a row, even though George stood us up yesterday. Inside joke, but I think many folks will understand who I'm talking about. I would like to begin today by acknowledging that I'm joining you from rainy Ottawa, which is on the traditional unceded territory of the Algonquin and Noshabeg people. And the Algonquin peoples have lived on this land since time immemorial. And my family and I are grateful to have the opportunity to live, work, and play in this territory. Next slide, please. So just to situate today's conversation, and maybe I can fast forward over some of this, recognizing that those of you in the crowd will be quite familiar with CIHR and its mandate. But in case not, I will just remind you that CIHR's mandate, as written in a piece of legislation called the CIHR Act, is to excel at according to internationally accepted standards of scientific excellence in the creation of new knowledge and its translation into improved health for Canadians, more effective health services and products, and strengthened healthcare systems. Today, CIHR has an annual budget of around $1.2 billion, and that funding goes towards supporting CIHR's mandate through these broad functions: knowledge creation, knowledge mobilization, and building capacity. And that's in addition to us serving as part of the Government of Canada's health portfolio and providing advice to our health minister, or in this case, our health ministers. Hopefully, you're seeing patient-oriented research as part of each of these functions. Next slide, please. Now, this one actually is going to go back in time, and it's going to go back to pre-SPOR times, which is more than a decade ago. Certainly predates my arrival at CIHR. And, there was a time when SPOR, Canada's Strategy for Patient-Oriented Research, did not exist. The SPOR team, I have to give my thanks to them. They went back to find some archival documents to share some of the thinking that went into the business case for SPOR at the time. And you see it here on this slide. I mean, most of this is going to be old hat to those of us who work in the patient-oriented research space. Although I have to say, despite excellent progress that's been made since this pre-SPOR timeframe, much of this is still true today. Next slide, please. So, what else went into the business case, if you will, for the creation of Canada's Strategy for Patient-Oriented Research? And again, on the slide, you'll see a number of factors, a number of pressures. These still exist, perhaps to a lesser degree today than they did before SPOR was created. But again, a number of factors contribute to the gaps that we saw and still see in the evidence to practice, evidence to policy continuum, including, right? I mean, you could probably tell me better than I can, the limited role for patients, even in patient-oriented research, a lack of clinical investigators, methodologists, epi folks, biostatisticians, information specialists, health economists, you name it. We needed, and we still need more of these types of practitioners. Certainly, complicated coordination of large, multi-center, multi-jurisdictional studies or investigations because of requirements around multiple ethics board reviews, lack of standardized contracts, difficulty sharing data across borders. Quite frankly, underfunding of patient-oriented research, especially when compared to some other countries. I've already mentioned the federated structure that we have here, which can contribute to the difficulties around coordinating research and sharing data. And I mean, the list can go on and on and on. So the fact that you're here today, part of the SPOR Evidence Alliance, I don't think I need to convince you that we needed a strategy then, and we continue to need the strategy. We continue to need SPOR now. Next slide, please. I like to share this particular slide because it marks the day, and it marks the point in time when SPOR became a reality. And, I will draw your attention on this slide to the words used at the beginning of this quote, by putting patients first. Also note the words used at the end of this quote, means improved health outcomes and a better healthcare system in Canada. Makes a lot of sense, doesn't it? And that last phrase is also reflected in the CIHR Act, the legislation that created CIHR 22 years ago. Coincidence? Perhaps, perhaps not. But suffice to say, right, it's always good to go back to documents like this in order to remind us of what the original thinking, the original vision was for the strategy. And again, from my perspective, those first four words, by putting patients first, need to be top of mind, front and center in everything that we do. And with SPOR, we're certainly doing that. Next slide, please. Now, I know you here, of all people, will be very, very familiar with the SPOR elements that have been in play for quite some time now. Certainly, the support units that exist now from coast to coast to coast, networks of varying sizes and foci, capacity development, and with the recent addition of the national training entity to the SPOR family, that is a very welcome development. Clinical trials, and specifically innovative clinical trials, patient engagement, of course, and I can't forget the enabling functions of SPOR, which are the SPOR Canadian data platform, now the basis for health data, the Health Data Research Network, and of course, the Evidence Alliance. Next slide, please. It's been a busy decade for SPOR, that's for sure. Starting back in 2011, when you saw in an earlier slide the announcement of the successful creation of the program. And again, I'm not going to go into a lot of detail here, but what the take-home message from this slide is really, we now have the building blocks in place for SPOR. We have support units, we have networks, we have initiatives around clinical trials, patient engagement runs right on through, capacity development, the NTE, and of course, the Evidence Alliance and the Canadian Data Platform. So that's just a little pictorial to show you that, 2011 was the announcement. Things really ramped up. Not that there wasn't any work going on in 2011 and 2012, but you started to see the fruits of those earlier labors starting in 2013 and carrying on all the way to the present day. Next slide, please. Which leads me to fast forward to our new strategic plan. And this plan, I guess, I said it was new. I think it's still considered new. It's about a year and a quarter old now, but it is a 10-year plan. And so when you think about, a year and a quarter into a 10-year plan, it's still what I would say in its infancy, or perhaps toddler years. Now, again, a 10-year strategic plan is pretty visionary. And, I will be honest that there were concerns expressed to us when the decision was made to go with a 10-year plan as opposed to a shorter 3 or 5 year plan that is more frequently seen. The desire here was for a generational change, right? To have generational impact on the trajectory of health research in the country. And by that very nature, there is room built into the strategic plan to allow for us to be flexible, nimble, agile as things come on scene that we really weren't expecting when we created the strategic plan. Perhaps like a pandemic, when the early consultations and engagements around the strategic plan were occurring, this pandemic certainly wasn't on our bingo or our dance card, depending on which way you put that. Next slide, please. So again, in case you're not familiar, and don't worry, there's not going to be a test, and we're not going to go into a great deal of detail on each of these priorities, but more for you to get a flavor of what the nature of these priorities. And so again, there are 5 main priorities, as well as an internal commitment to organizational excellence. And I know many of you helped us create this strategic plan. Now, we spent 2 years before it was launched engaging with individuals and groups who are part of the health research ecosystem in order to, dream, scheme, strategize, identify where we want to be and how we would like to get there together. Now, again, I'm not going to go through all of these in a great detail, but as I mentioned earlier, I do hope that you can see yourself and patient-oriented research in any 1, 2, 3, 4, 5 of these priorities. And if you don't yet see the connection, you soon will. And what I might do right now, I'm going to keep an eye on the clock because I want to make sure we've got ample time for discussion. I'm going to take a little bit of a deep dive with priority E, which is named integrate evidence in health decisions. So you may be wondering why I, CIHR's Vice President Research for Learning Health Systems, is here talking all about patient-oriented research and learning health systems. Yet if you look at our strategic plan, the phrases patient-oriented research and learning health system don't appear. In fact, CIHR's Citizen Advisory Committee that supported us in the development of this plan, they did go through the strategic plan word by word, and I think the word patient may appear only once or twice. Now, this is certainly not because we didn't consider this phraseology or that we weren't putting patients at the center. In the end, we went with the language that you see here. And for priority E, we went with the language of integrate evidence in health decisions to ensure that this plan was inclusive, if you will, in terms of supporting, I was going to say allowing, I'm going to say supporting everyone to see themselves in this particular plan. Not everyone is yet part of a learning health system. Not everyone yet has embraced patient-oriented research. I know there are pockets and parts of the country that are well on the way in terms of a journey towards learning health systems and actively embedding patient-oriented research therein. Others are still at an earlier stage, and others still are contemplating it. So again, just in the spirit of sharing honestly, that's why you're not seeing some of that language that you might expect in the strategic plan. Another reason is that this strategic plan was actually, quite baked, if you will, prior to the pandemic arriving. And we held off on releasing the strategic plan because we, like you, were focused in on other things, namely dealing with the pandemic. And so when it came time to release the strategic plan, the world had also evolved. So the learning health systems phraseology, patient-oriented research, they continued to grow, right? They continued to gain followers. The strategic plan's wording, though, just reflected the consultations that we had done earlier on. So maybe I'll just jump to the next slide rather than kind of have my therapy session here with you today. But all to say, wanting you to know that when you see that phraseology, integrate evidence in health decisions, and I should also note priority D around pursuing health equity through research, I want you to look for and think of opportunities for patient-oriented research and learning health systems to be right in there, baked in, woven in to all of the activities that are happening there. Next slide, please. Which now brings me to touch on the concept of learning health systems. And as Andrea noted, my title at CIHR shifted in February of this year. Prior to that, there was one VP research at CIHR, and so I oversaw the research programs portfolio, which included many of the things that are within the portfolio that I lead right now, as well as the delivery of all of the funding competitions, the peer review panels, the institute support. And as you can imagine, CIHR has a lot of funding opportunities and a lot of peer review panels. And so what we were finding is we were very much being drawn into the day-to-day, the operations, the just things that needed to happen, and of course that reflects the a very important role for CIHR within the ecosystem is to be a funder. But what it meant was that there wasn't much bandwidth left for me, for others, to actually think about more strategic initiatives, such as those that you now see within this new Learning Health Systems portfolio. And again, if we go back to a motivation for this change, partially due to that strategic plan that I spoke about a minute or so ago, but it also goes right back to that CIHR Act, the piece of legislation that created CIHR in the year 2000. And again, remembering that CIHR's objective is to excel according to internationally accepted standards of excellence, creation of knowledge, and its translation into improved health and healthcare systems for Canadians. So again, I'm going to keep on emphasizing this. We exist, we, CIHR, and by virtue of that, all of the things that are funded through us exist to improve health for Canadians, to support more effective health services and products, and to strengthen our healthcare systems. And so in a lot of ways, in a lot of ways, I'm very excited about having the opportunity to lead this new portfolio. I've been given a great deal of liberty, if you will, in terms of bringing things together, have brought in a number of new individuals to the team, and I'll mention them to you a little bit later on. But of course, I see the enormity of the challenge that lays in front of us. And when I think about all that's been done, I do really, really still wonder about how close we are getting to achieving these objectives that have been set forward, not only for CIHR, but for SPOR more specifically. And don't worry, it's not all doom and gloom. It's actually a bit of a rallying call for us to get excited, to keep doing the great work that we've been doing. And by we, I mean you, and to look for opportunities to make this even better. Next slide, please. Now, I'm sure we've all seen these figures, and this actually relates to my last point about how well are we doing in terms of achieving these lofty objectives of improving health for Canadians, making our healthcare systems more effective. These figures, and I happened to pull this off of Twitter probably earlier in the winter, essentially describing the two valleys of death that occur in translational research. So the first valley of death relates to the translation of lab discoveries to humans, while the second valley concerns the translation of that resulting evidence into policy and practice. No matter how you describe it, 17 years for research to reach practice is way too long. I say this now being the mom of an 18-year-old, and if I think back on the past 17 years, boy, it feels like a long time. Perhaps even more damning is the second statistic, that only 14% of research reaches a patient. And I cite here some work out of Quebec that suggests that less than 1 in 5 healthcare practitioners, healthcare admins, report using evidence-based practices frequently. Now, I know if you're able to read the fine print there, you'll say these references are a bit dated, Tammy. And I agree. And, there's probably been some improvement over time. But I dare say, even if there has been some improvement, these values are still going to signal significant room for us to do better. Which brings me to the next slide, please. And the concept of research waste. And I know that this will be quite familiar to many of you in the audience today. This is work, this particular schematic comes from a 2009 publication in The Lancet by Ian Chalmers and Paul Glasziou. And they've done their homework. They've updated this work and it still stands true, but 85% of research is wasted. Usually because it asks the wrong questions, is badly designed, not published, or poorly reported. This diminishes the value of the research for sure, and represents a significant financial loss. Back in 2009, Chalmers and Glasgow estimated that this was over $100 billion a year in research waste. So that could fund 100 CIHRs. It could also fund a lot of other things within healthcare systems, the education system, the environment, you name it. It goes on and on and on. It also, to me, poses significant ethical concerns when this research isn't reported in the public domain, isn't reported in a way that's reproducible and replicable. And again, as Chalmers and Glasgow note, and I would agree, many of the causes of this waste are simple problems that could easily be fixed. And I would say that patient-oriented research, together with a learning health systems approach, where patients are involved upfront and all the way out through the process, can help address at least some of this research waste, particularly in terms of that very first stage where research agendas, research questions, and outcomes are set. Now, the fact that you're here, part of the SPOR Evidence Alliance, suggests that, well, at least it makes me think that you may agree that patient-oriented research will at least help us reduce that research waste estimate a little bit, or maybe a lot. Next slide, please. So anytime I think about the health evidence ecosystem and of research waste, I'm reminded of this quote from the late Doug Altman. I had a chance to meet Doug on September the 11th, 2001, when I was a sponsored scholar attending the BMJ JAMA Peer Review Congress in Barcelona. I remember that day for many, many reasons, but certainly Doug and his discussions over dinner that night left a lasting impact on me. Doug wrote this quote in 1994, almost 30 years ago. I'd ask us to consider, how are we doing in this regard? Next slide, please. I'm going to say not too well. And I shared this paper on Twitter yesterday, and I know some of you, I tagged some of you in the tweet. It's hot off the presses work done by the Trial Forge team in Aberdeen. And it's speaking about clinical trials and whether the primary outcome selected by the trialists actually agreed with the primary outcome that patients and health professionals would want. So essentially comparing two groups of folks, one group who picked the primary outcome in the trials, the other individuals who actually would be participants in the trial. And guess what? In this particular study, patients and healthcare professionals agreed with the choice of primary outcome made by the clinical trialists. And this was late stage trials in breast cancer and nephrology. The agreement happened 28% of the time. 28. That's not good. And of course, this not only affects the individual clinical trial, but it also affects how we, you, me, others who are active in the evidence synthesis ecosystem, synthesize all of this primary data together into systematic reviews and meta-analyses. I mean, it's up to us to make sense of the primary studies, and this is regardless of whether or not we're pooling the results quantitatively. When outcomes don't align across studies, it makes your work, it makes our work even more challenging. And of course, at the very core here, these trials are then not addressing what matters most to patients and their caregivers. Next slide, please. I would be remiss if I didn't talk a bit about the San Francisco Declaration on Research Assessment, or DORA. And many research funders, including CIHR, are signatories to the DORA statement, which recognizes the need to improve the ways in which the outputs of scholarly research are evaluated. For us at CIHR, we're currently undertaking a big piece of work to broaden what is meant by research excellence so that measures of impact beyond publications are counted. Remembering again that CIHR's mission is to create new knowledge and to enable its translation into improved health and more effective health systems. And of course, it goes without saying that scientific publications are an important way of sharing new knowledge, but publications in and of themselves are outputs and not outcomes. So how can we increase the impact of the research that we fund? How can we address the issues contributing to research waste? How do we really, truly improve health and healthcare systems? Again, for me, this is all coming back to putting patients first, supporting patient-oriented research, and as a result, supporting learning health systems. Next slide, please. Which brings me back to CIHR. What we've done, what we're doing, what we plan to do to support patient-oriented research across the country. And I know many of you will be familiar with some or perhaps all of these programs and initiatives. Of course, top left corner, there's SPOR. Bottom left-hand corner is the Health System Impact Fellowship. And I have to give thanks to CIHR's Institute for Health Services and Policy Research, because really they were the ones who brought this program to life, and it's been a tremendous success story. Bottom right corner is the knowledge to action cycle that underpins so much of our work, whether it's evidence synthesis, whether it's primary studies, whether it happens to be some policy work that we're doing. And again, I have to give credit to Dr. Ian Graham, who was CIHR's Vice President of Knowledge Translation back in the early 2000s. So there's been a strong link on the knowledge translation side at CIHR as well. Top right corner, a little visual there all about open science. And Jesse, I see that you're here, and I'm sure we could talk a lot about open science, perhaps at another time. But CIHR has had a fundamental interest in ensuring that the findings that result from the research that CIHR has funded are available to the widest possible audience at the earliest possible opportunity. And again, I think the open access policy at CIHR dates back to 2008, when it was indicated that the costs of publishing open access would be considered to be eligible expenses on CIHR grants. And since the early 2000s, CIHR has recognized preprints as an important vehicle for the dissemination of research results. Now, I know there's issues, right? We need to kind of have our eyes wide open when we're looking at preprints. But again, especially in a pandemic context, when the speed of science has been so fast, preprints are adding to our knowledge base in a way perhaps that they hadn't before. I will note that at the very core of the work that we do at CIHR is a commitment actually by the Government of Canada to using Gender-Based Analysis Plus, or GBA Plus, to develop effective policies and programs. And GBA Plus, if you're not familiar, I'm happy to put a link in the chat later on, is an analytical tool used to assess the potential impacts of policies, programs, services on diverse groups of people, taking into account sex, gender, and other intersecting identity factors. Now, I have to say, all of these activities existed at CIHR before I joined the agency, before the creation of this new Learning Health Systems portfolio, and before CIHR's current strategic plan was launched. That said, these activities were typically occurring in silos without concerted efforts at cohesion and coordination. And as a result, we weren't necessarily learning from each other, even within the same agency. We weren't making the most of existing assets, if you will. And quite frankly, we were missing opportunities to have an impact, which to me means making a difference for the health of Canadians and our healthcare systems. Next slide, please, which takes me to the present, which is the creation of this new learning health systems portfolio at CIHR. Now, it brings together, it's a new portfolio, but that doesn't mean everything that sits within it is new. We have some things that are new and they're flagged on the slide, and some things, some teams that have existed at the agency for quite some time. The fact that these groups, these teams, these branches have been brought together under the Learning Health Systems banner is really going to enable coordination, collaboration, capacity development in order to, learn from each other, to break down those silos that had existed, beforehand. And again, given all of us are working and supporting healthcare systems, I think we understand that silos may be good on the farm, but not when it comes to our healthcare systems and learning, sharing, and being able to support scale up and spread of effective interventions. This portfolio is also going to be working closely and in complementing federal, provincial, and territorial activities, as well as other stakeholder efforts, including with the provincial health research organizations. Next slide, please. So this is just a very quick reminder. Again, remember that slide about the CIHR strategic plan, 5 priorities plus 1. Let's go to the next slide, which will show you just how nicely SPOR and POR, patient-oriented research writ large, if I could say, are foundational to implementing CIHR's strategic plan. Again, I'm not going to go through this in all detail, but suffice to say, even though I was emphasizing priority E, patient-oriented research, in fact, is touching on every single priority within CIHR's strategic plan. Next slide, please. Now I get to talk all about SPORE and the impacts of SPORE, and this really is an exciting opportunity for me. I have to admit that I'm often asked the so what questions, right? So what's the difference SPORE has made? So what's the difference that investment, in patient-oriented research, what difference has it made to Canadians? On this slide, you can see some highlights of SPORE's first evaluation, and that was done back in 2016. And we've also noted some additional insights on the slide. There is a lot to like here. And if you've looked at the 3 active funding opportunities for the Clinical Trials Fund, and I'm sure that some folks on the call have, you'll see patient-oriented research language woven in there too. And there will be even more of this mainstreaming, if you will, of patient-oriented research across CIHR initiatives to come. So keeping your eyes and ears open to see patient-oriented research kind of moving beyond SPORE, if you will. That being said, the 5-year evaluation, again done back in 2016, did suggest some adjustments are required in order to improve performance. And I'm not going to go into those in detail, other than to say the evaluation that was done in 2016 actually has spurred changes, tweaks, enhancements, if you will, in order to address those areas for development that were picked up. One example being, let me just see, anticipated interactions between the core components. So do support units work with the networks? Do networks interact with the Evidence Alliance? That sort of thing. And again, there's been forward movement on many of those items that were picked up in that earlier evaluation. And these changes will be captured in the 10-year evaluation that's currently underway. Next slide, please. I do have to acknowledge the absolute immense contributions of the Evidence Alliance to the Government of Canada's pandemic response. And I really, really, really hope that each and every one of you take pride in the work that you've done to support the country and many others, in fact. As COVID emerged, the Evidence Alliance was very quick to partner with others, including COVID End, to help coordinate and reduce duplication of COVID-related research, knowledge synthesis, and other activities. I know the Evidence Alliance has also partnered with the Maritime SPOR Support Unit, for example, to share library services in responding to their COVID-related research needs. And to my good friend and colleague, Andrea, Dr. Trico, is again, a founding member and moderator of the Knowledge Synthesis channel of COVID End. I have no idea where you find the time to do all of this amazing work and be a wonderful mentor, colleague, and friend. But again, sincere thanks on behalf of the Government of Canada for pivoting and for prioritizing COVID-related work at this very unprecedented time in our lives. Next slide, please. So what's new at CIHR? Well, there's a lot new at CIHR, and there's a lot new with SPORE. And it would have been great today for you to have a chance to meet Dr. Amy Lang. So Amy is our new Executive Director for Patient-Oriented Research at CIHR. Amy actually is on vacation with her family this week, I think up in Blue Mountain on the shores of Georgian Bay. She really wished she could be here, but looks forward to future opportunities to meet with you. I've noted Amy's Twitter handle here. Again, I know many of you are active on social media, and so if you haven't yet followed Amy, please do so, and I know she will follow back. Importantly, one thing I did want to flag to you is that you'll note Amy's title is Executive Director for POR, right? Patient-Oriented Research, not Executive Director for SPORE. And this was intentional. Amy and her team will continue to be responsible for SPORE, but as I will tell her and the team, POR is more than SPORE. And I will stop it with those, cheesy rhymes, but we are looking to Amy and the team to actively embed patient engagement and patient-oriented research across the agency, initiatives, programs, institutes. And so again, with thanks to SPORE, which will continue to, exist and, be hosted by this team, we are now looking to embed a patient-oriented research lens philosophy across as much work that we can in the agency. And so again, you can look forward to outreach from Amy if it hasn't happened already. Amy joins CIHR from Ontario Health, where she designed and delivered patient, caregiver, community, and stakeholder engagement strategies, again, with the aim of improving the healthcare system. So that's one little bit of news for SPORE. Next slide, please. What else? Well, it's been busy, again, with funding opportunities, and I know many of you are engaged in these activities as well. So we've got some new SPORE networks that have come online. In terms of the support units, again, the Yukon Support Unit, which was funded in late 2020, is ramping up its phase 1 activities. And the renewal of the support units will continue to champion patient engagement and integrate evidence in health decisions, maximize results for Canadians through a new learning health system component. So there was a little bit of a change up in terms of what we were asking of the support units with their renewals. And again, the support units themselves have all been renewed. And so we've got a lovely community of practice in the learning health system space. I don't want to miss the opportunity to note that the National Training Entity was funded in March of last year. And again, just a welcome addition to this portfolio. So really, really pleased to see this, this all coming together. Next slide, please. Some other things that are new, and I will just draw your attention to these. again, the patient-oriented research training grant health system stream, and happy to put the links to these in the chat. The think, right? Transforming health with integrated care. We've got implementation science teams. That funding opportunity is now active. And we are looking to bring online an integrated youth services network of networks for child and youth mental health. So there's, a lot of things, right? The backbone of SPORE in terms of the platform-like activities have continued. And over time, as the evidence evolves, as the needs of the country evolve, we bring online some new opportunities. Next slide, please. I'm getting close to the end, Andrea. So where to from here? And yes, I do like the fall. I also like the spring. And so I hope no one's getting mad at me for showing a slide of the fall when we're just embarking on the summer right now. Next slide, please. I've mentioned the second SPORE evaluation that's happening, and it's happening right now. It reflects the past 5 years. So you'll see from 2016 to 2021, this is part and parcel of our accountability requirements to the federal government. And of course, right, I don't want you to think that we're doing the evaluation simply because we have to do the evaluation, but also that this evaluation will really, truly inform program improvement and decision-making with respect to SPORE's future direction, planning, sustainability. And so again, to underscore this, the evaluation will happen, we will receive the results, and then with others, we will make any programmatic changes or adjustments that are required. We are expecting this evaluation to be completed by the end of this calendar year. So it's moving forward. I had my key informant interview last week and had a great chat with the evaluation team. So if you haven't already, you may very well be contacted to be part of this evaluation as well. Next slide, please. Related to the evaluation, there will also be a SPORE governance and strategy refresh. The word refresh kind of gives you a hint that we're not looking to, turn everything topsy-turvy, but rather recognizing the building blocks of SPORE that are in place. Are there things, again, that need to be adjusted, things that might require some additional emphasis? This refresh work is going to, the planning for it will start this fiscal year, but of course cannot get started in earnest until we have the results of the evaluation that I mentioned. Again, we're going to be looking at whether, or maybe it's how close we are getting to achieving SPORE's vision, which again, over on the right-hand side of the slide, is to demonstrably improve health outcomes and enhance patients' healthcare experience through integration of evidence at all levels in the health system. So again, I think we're making progress to it. I don't think we'll be able to say at the end of this, we've done it, time to go home. And I think you would agree with that as well. Next slide, please. I think there's only 2 more slides to go. When I introduced Amy, Dr. Amy Lang, to USCIHR's new executive director for patient-oriented research, I mentioned that in addition to being responsible for SPORE, she will be actively looking to embed or mainstream patient-oriented research and patient engagement across CIHR writ large. And on this slide, I've noted a few opportunities that we see as being ripe for incorporating patient-oriented research beyond SPORE. I've already mentioned, or at least alluded to the Clinical Trials Fund. And again, I probably won't say any more on that. Happy to answer any questions though, if it comes up. What I haven't mentioned yet is CIHR's new Center for Research on Pandemic Preparedness and Health Emergencies. And this exists now thanks to dedicated funding in the federal budget of last year. And really, it's about growing our capacity to prevent, prepare, respond, and recover from pandemics and other health emergencies. the good news here is that in the most recent federal budget, CIHR received an additional $20 million for funding in long COVID research, and this funding will run through the center. I can't share too many details about this upcoming opportunity on long COVID with you because we're working on the Treasury Board submission. But suffice to say, when you see that long COVID funding opportunity come online, you will see that it's been written with and through a patient-oriented research lens. I mean, the same thing goes for the clinical trials fund opportunities, and I know many people are scrambling to get those applications in for those July deadlines. And again, we're doing this not with a lot of fanfare, not with a lot of spotlight, but rather we're embedding the language in the funding opportunities to make it clear about our expectations around having patients included, patients truly included, and applying a POR lens to research question identification, outcome selection, and so on, and so on, and so on. In terms of knowledge mobilization, again, huge opportunities for patient-oriented research there, and I'd say the sky's really the limit. I'm encouraging the team right now to work towards systematizing the premise, an underlying premise, that we should always be thinking of mobilizing evidence, not only for policy, not only for practice, also for patients and persons with lived and living experience. So to me, it's kind of like a P3, although I know that that nomenclature can have other connotations, but policy, practice, and patients. And I know the Evidence Alliance, you are already well ahead of us and in fact, I'd say the world in terms of this philosophy or orientation. And I see what you're doing here as being best practice. And I think others need to follow suit. As part of reimagining our KM, knowledge mobilization activities, I do see an important role for a POR lens to be applied to many of our activities, and I'd say including, but certainly not limited to, prioritization of research topics, of research questions, of developing core outcome sets to identify the outcomes that matter most to patients, of identifying gaps that remain or new gaps that are created when research is completed and implemented into our healthcare systems, because those gaps need to feed back into a process whereby a research funder, e.g. CIHR, can then allocate or attribute funding to addressing those gaps. Again, kind of analogous to a learning health systems approach. And so the cycle goes. Finally, bottom right corner, it goes without saying that at the heart of all of this is or are data. We're all aware that Canada's awash in data. It's not, it's not that we don't have data. It's just that it's not necessarily curated or accessible in a timely manner, partially thanks to our federated system. And in case you weren't aware, there is some excellent work that has gone on during the pandemic vis-a-vis a pan-Canadian health data strategy. And right now, there's an opportunity for you to comment, if you wish, on the work that's been done to date. And I will put that link in the chat because, again, I think it's important for all of us within this ecosystem to know what's being proposed and to be able to shape it based on your experience. CIHR has been part of these conversations, and we are at the table. And I can share with you that patients have been engaged in these discussions. And I'll also share that these conversations with patients have had a direct and noticeable impact on the positioning of this data work. All to say, there are plenty of opportunities and engagement makes a difference. If I could skip maybe a couple of slides to the one that has puzzle pieces in it, please. Perfect, thank you. So again, I've already given this away. We've got the pieces of the puzzle on the table, and now it's up to us collectively to put those pieces together in a way that optimizes our investments, right? Whether it's money, or time, and our expertise in a way that truly benefits Canadians in the way that SPOR and CIHR were always intended to. I do hope that you'll continue to be part of this journey with us. And at this point, I really welcome your thoughts, comments, and questions. With that, Andrea, I'll turn it back to you.
Great. No, thank you so much, Tammy. That was an incredible presentation, and I really love moving the poor beyond SPOR. I'm going to use that. That's so corny, and I'm a corny person, so I love that. So thank you so much for sharing that. And no, I mean, you had such great inspiration for us. So using patient-oriented research to reduce research waste, talking about DORA, open science, moving beyond the publication, the equity GBA plus, and congratulations to you with your learning health system portfolio, which is also quite massive here with EDI, SPOR, the pandemic preparedness trials, etc. And we're just very excited to see, the impact and how patient-oriented research is part of the strategic plan, even though it's not formally listed. We see how it is embedded throughout. And also we're excited about the evaluation and hearing next steps. So huge thank you. So I'm just going to, I know that we don't have a lot of time, but I would love to take one or two questions. So Annette had a nice question in the chat. Annette, would you like me to read that question for you? Or would you like to read it out?
No, it's fine if you do. Thank you.
Okay, I'll read that for Annette. So Annette was asking, it might be difficult to explain to new patients who want to be involved that they are welcome partners in research when they don't see patients explicitly mentioned in the new strategic plan. And are the points you mentioned also on the later slide also public?
Really great question, Annette, and I really appreciate it. And you know, I mean, this is exactly the conversation we had with the Citizen Advisory Committee, because, you know, I mean, many of the members of the Citizen Advisory Committee became involved with the strategic plan through their involvement with SPOR. And so we you know, it's kind of like we already had those who had drank the Kool-Aid, if you will, right? We had people who knew about CIHR, they know about SPOR, they know why this matters. And so it really was, I would say, so helpful for them to say, you know, we see it, right? We get it. We understand this, but other people will not. And, you know, again, the strategic plan is what it is. You'll see, you know, it's there. But now there's an opportunity for me and others with the creation of this new portfolio to kind of bring that strategic plan to life. Again, I don't want to say, oh, they're words on a page, but now, you know, like, what does it mean? Because you can read some of those words and, you know, I will say some of them you could probably drive a truck through because they're just so broad. But if we together, right, can bring this to life, give concrete examples of, you know, what does this actually mean and how are patients involved or persons with lived and living experience involved, I think that will be potentially more impactful than having words in the strategic plan. Because again, when we hear about, you know, if I hear from Andrea, you know, you've got to go to this new restaurant, right? I'm like, okay, I'm going to go to this restaurant. Not right now when the pandemic's over. So I think that word of mouth, the community of practice that we have, and maybe in that just one, I know we're running out of time, but when SPOR did a survey last summer, we were looking at creating the next list of priorities, the list of priorities for the next 5 years. We actually had patients responding to the survey who had never been involved with SPOR before, which I thought was amazing, right? To take time out of your schedule, respond to a survey, and they had no knowledge of SPOR. So I think there's something there. Completely agree. Communication is going to be critically important. So all to say, I take your point. And I will also note that Linda is a member of that Citizens Advisory Committee that I mentioned as well.
Excellent. And so I saw that Maureen Smith had her hand up next.
Oh, thanks, Andrea. Hi, Tammy. Thanks for that great presentation. I'll be very brief so you can get other questions. And I have a question about the learning health systems. So I noticed that in your presentation, it's always support for learning health systems. So I'm involved with the Ontario Learning Health Support System. And then I realized, well, every province seems to have one, and they're all producing materials, and we're not aware of what's happening. So like, oh, Saskatchewan has a great video for patients, etc. Is your goal to bring those people together as a federal body and, work on best practices? And do you see enough commonality in all of those support systems that are, those learning health systems that are out there, that you can actually create something where we can work together as a pan-Canadian group, so to not duplicate the efforts?
Maureen, you've read my mind, and that is one of the things that I really want to see happen again. Now that we've got the various building blocks in place, what I would like to see is, the connectivity, if you will, between the various entities to do exactly what you've said. I mean, there may be areas of strength or pockets of strength where we could say, actually, Ontario, really like, this training module that you've prepared. BC, I really like the one that you've done on health economics. Can we curate this so that, right, we've got, I don't want to say a one-stop shop, if you will. I'm very careful about federal space and provincial territorial space, but I do think, again, there's that recognition that we may be duplicating, and by doing so, not only inefficient use of resources, but potentially confusing people, including confusing those who have not yet joined this community. So I would say for Amy and team, that's been one of the things that I've said is we have to take stock of all of these tremendous assets across the country and then find a way to enable, the sharing, the collaboration, the curation that needs to happen. So absolutely.
Great, thank you so much. And I'm just being cognizant of time. Tammy, there's so much interest here in what you're saying, so thank you so much again. So Bev Pomeroy was asking if the new E8 guidelines for clinical trials had a POR focus on it.
I don't actually, I'm going to admit my what E8, what are the E8 guidelines?
Do we have Bev Pomeroy? Oh, here I see
Yeah.
Bev there.
Just the new E8 guidelines in clinical trials that's been passed in legislation, international legislation for clinical trials, indicates that patient engagement needs to be throughout a clinical trial from beginning to end. So I'm just curious if that was a bit of an impetus for some of the focus on the clinical trial work report, because it is relatively new.
Exactly, and I would say maybe not an impetus, but a serendipitous of findings. So there was also some work that happened last year, last June actually, when the UK was lead for the G7, and they came out with a new clinical trials charter that also spoke to the importance of patient engagement from beginning to end. So I'm seeing a lot of kind of coalescence of different bodies, and for me, I mean, this was always in the back of my mind even before I got this portfolio was, clinical trials. Well, I mean, the article that came out earlier this week from our colleagues in Aberdeen showing just how poorly primary outcomes in clinical trials match to what patients, and I had seen earlier literature on that. So it probably wasn't the impetus, but I'm glad that others are doing the same, because it'll definitely support what we're collectively trying to do together. Thanks, Bev.
Great. And just, I think there was one last point that a couple people have mentioned, and I see Rita has her hand up, but looking at rebranding. Yes. So Rita, did you want to elaborate on your comments in the chat?
Yes. So the reason I brought that up was as a patient partner myself, and being quite involved and hearing at so many groups that, we really, just mixed feelings about the very words. And I have a little bit of a background in outreach and that sort of thing. And I just feel that sometimes we as patient partners, our voices kind of get neutralized and into the background. And I'm so glad to hear that Tammy's group is has got something going in the sense of a rebrand. Personally, I think it's a cause for a little bit of celebration and just getting the word out there that we as citizens, we like to be involved. We want to be involved. And if there's a way to do that within the structures that are currently existing.
Terrific question. And I wish Amy were able to be here with us, because we've been also talking about this. And, it's, for example, our work with Indigenous communities, the word patient doesn't really resonate. They very much approach this, community-based, research. Patience is also a term that can be laden or loaded with particular meaning. And so also say, I would welcome an opportunity for a rebrand or a rethink. Again, the P in SPOR, strategy for patient-oriented research. Could it be strategy for persons? You can kind of, I'm sure there would be some marketing company who could help us with a rebrand, but all to say, where we were back in 2011 versus where we are now, it's a very different space. And so again, thinking about this broadly also goes along with the phraseology of engagement, involvement. I know there's a continuum. We see people mix and mash, but maybe there's an opportunity here for SPOR to come together with an agreement around terminology or nomenclature. But agree. And we, of course, think of it in the broadest sense possible, but I don't think everyone does.
Tammy, I would suggest instead of patient, instead of the word P, maybe using human for H, but that requires a little more effort, I think.
That's great. Thank you so much, Vikram. And thank you so much for this great discussion. And again, I think we could probably talk all afternoon about this, but we want to be cognizant of your time too, Tammy. And thank you so much for joining us and your talk. It was incredibly enlightening and very hopeful for the future. So huge thank you. And thanks to all of the individuals who asked questions and were engaged. So this is fantastic.